Vamos a desarrollar el módulo y si vamos bien con los tiempos, vamos a tratar que las preguntas se hagan luego de cada conferencia para evitar estar subiendo y bajando del entrado. El profesor Gharavi es profesor y jefe de servicio de nefrología del Presbyterian Hospital de Columbia, New York. Es profesor asociado en medicina interna en el citado establecimiento. Y como ustedes saben, tiene numerosas publicaciones vinculadas a los trastornos genéticos en diversos tipos de enfermedades renales. En la oportunidad para este módulo de enfermedades glomerulares, en este evento de medicina de precisión, le hemos solicitado que verse en torno a la genética en el tratamiento de la nefropatía por inmunoglobulinada. Doctor Gharavi, por favor.
Inviting me to this very common in East Asia, particularly it's the most common cause of kidney failure in China and in Japan. It's rare in Africa and it has intermediate prevalence in Europe, North America, and probably in South America, although the epidemiology hasn't been mapped out as well. It presents in the second and third decades of life in the setting of mucosal infections. There's 20 to 30% of patients who go on to develop kidney failure. And this is the major question to most clinicians who see a patient with IgA nephropathy. Who is the patient who's going to need to determine who's the patient who's going to go on to have kidney failure based on the data that's in front of us, and that's what we struggle with the most. It sometimes overlaps with other immune-mediated diseases. And one of the issues that we're frequently dealing with, particularly nowadays, given new data that's come about therapeutics, is that the treatment pathways are not really clear beyond renin-angiotensin blockade. So, the outline of my talk is really about the pathogenesis of IgA nephropathy, at least for a current understanding of the pathogenesis, how much genetics has helped in terms of understanding this pathogenesis, and what have we learned doing these genetic studies into the epidemiology of disease and some of the clinical implications. I'll talk a little bit about prognostic factors and about treatment as well. So, one of the fundamental problems in IgA nephropathy patients is that they have abnormalities in the glycosylation of immunoglobulin A in circulation. So, IgA is composed of two subtypes, IgA1 and IgA2. IgA1 is the one that's most common in circulation. And IgA1 is different in the sense that it has this hinge region that is very rich in serine and threonines. And these can be all glycosylated. So in other words, there are sugars that can be attached to the hinge region of IgA, and that's sort of the normal pattern for post-translational modification. And so these threonines and threonines are decorated then with an N-acetylgalactosamine, so GalNAc, which is then to which is attached a galactose, and finally a sialic acid. And so this is sort of the normal configuration that we have in our serum for the most part. There's an alternative configuration which lacks galactose, and in which the N-acetylgalactosamine is essentially coupled to sialic acid. This configuration is much more common in patients with IgA nephropathy. We all make a mixture, but patients with IgA nephropathy make a lot more of this. And it turns out this particular version of IgA is more prone to forming immune complexes. It is cleared less efficiently by the kidney. And so it might be, it's a major pathogenic steps. We can measure the levels of the lactose-deficient IgA in the serum of patients using an ELISA. So we've collaborated with a number of groups, particularly Jan Novak at the University of Alabama, to study this. And let me give you an example of a family in which we have 4 people who have IgA nephropathy by biopsy, and then here's the rest of the family. And this family gets together every 2 years for a reunion, and we have been going to their family reunion, and we've drawn blood from them to measure the levels of galactose-deficient IgA. And so that's one of our first findings that we had, was that we measured the levels of lactose-deficient IgA in controls, and you can define, it's a quantitative trait, so you can define the 95th or the 99th percentile for this trait. And then you can measure the level in IgA nephropathy patients. patients, they're all elevated above the 95th percentile. And what was really interesting was that about a quarter of the relatives, healthy individuals, now healthy relatives, also had levels that are just as high as the patients. So this told us that this is an inherited factor in the development of IgA nephropathy. In contrast, individuals who were not genetically related to the proteins and were married into the family had levels that were essentially indistinguishable from the controls. So this told us really important information about familial IgA nephropathy, and then we went on to look at this also in patients with IgA nephropathy who don't have a real family history of disease, and we saw the same thing. About 80% of them have levels that are above the 95th percentile, and about a quarter of their relatives also have elevated levels. Now, we've been following these relatives for over a decade now, and none of them developed IgA nephropathy. So they have a similar biochemical defect in the level of galactose-deficient IgA, but they don't develop disease. So this told us that first, here's an inherited risk factor, but it is not sufficient for the development of disease. So there must be additional factors involved. And so, work from Jan Novak's lab and a number of other labs have shown that likely the second step is likely the generation of these anti-glycan IgG or IgA. In other words, the galactose-deficient hinge regions become antigenic targets for the immune systems for reasons that we don't quite understand. And so this leads to the formation of immune complexes that contain IgA, and then anti-glycan IgG and IgA. And again, here, this is a paper which describes the levels of this anti-glycan IgA or IgG in the serum of patients with IgA nephropathy. You can see this is highly elevated compared to disease controls and healthy controls. So we think these are the two major steps in the pathogenesis. So we've also participated in a large number of epidemiological studies looking at the prognostic value associated with the levels of galactose-deficient IgA. And here, looking at the left, this is a study from a cohort of patients from China where we looked where the levels of galactose-deficient IgA determined at the time of renal biopsy. It was divided into quartiles. And you could see that individuals who had the highest level, here in group 4, had the fastest progression to kidney failure. Now there's a lot of overlap, so this is not a perfect test, but it tells you that in general, the sort of the antigenic load, the genetically determined antigenic load, is an important factor in the development of disease. Similarly, the levels of anti-IgA antibody levels, these anti-glycan antibodies, is also prognostic. And so this is another study. This is from also from a French group, from François Berthoud, who I just recently found out he passed away, unfortunately. He's a fantastic investigator in the field of IgA nephropathy. So this is looking at the French cohort now, looking at the level of anti-glycan antibodies. And you can see again, the higher the level of these anti-IgA antibodies, the worse the survival is. So the problem with these tests is that they are very difficult to develop as a clinical test because there's a lot of noise in these assays. And so on a research level, they're really important proof of concept, but we've had difficulties bringing these on as a clinical test to help clinicians with decision making. So one of the things that we've done in my lab is to conduct a lot of genetic studies of IgA nephropathy from using cohorts of patients from all over the world. This is a summary of essentially 10 years of work from our group and other groups, where this is a study looking at 20,000 individuals, about 6,000 of them had IgA nephropathy, and then the rest of them were controls. And here we did a genome-wide association study. In other words, we looked at genetic markers that increased risk of disease in these patients. And this is called the Manhattan plot. Some of you may already be familiar with this. This is on the x-axis, you see all the chromosomes. On the y-axis, this is a metric of significance, minus log p-value. So for example, 10 indicates 10 to the minus 10 in terms of significance of association. Each dot represents a single nucleotide variant in the genome, a single marker in the genome. And so the peaks that you see in red are the regions that are associated with risk of IgA nephropathy in our genome. So the first observation that we made here in the study is that there's a very strong association with the MHC, the HLA locus, with IgA nephropathy, which is something that was not really clearly appreciated before we did these studies. So this really put IgA nephropathy in the spectrum of other autoimmune diseases such as lupus or type 1 diabetes, there's a very strong association. And it kind of makes sense if you think about it, because here you have an autoantibody that's being generated, and so usually whenever you have an autoantibody generation, the MHC locus seems to be involved. We found a number of other signals that are involved in innate and adaptive immunity, which I'm not going to have a lot of time to go into. A major one, for example, here was in the defensin locus. Defensin alpha is an antimicrobial peptide that's generated by mucosal surfaces, particularly in the GI tract, in response to invading microbes and pathogens. And so this really told us this is mucosal immunity pathways that are involved in the pathogenesis, and people who have lower expression of defensin alpha seem to have a higher risk of IgA nephropathy. Another really interesting signal that we identified was in the complement system. As you know, in IgA nephropathy, you have deposition of C3 as a really common finding. However, C3 is present in the absence of C1q, indicating that the alternative complement pathway is involved. Well, this signal is right in the is in genes right in the alternative complement pathway. And so let me tell you a little bit more. If you remember, there are different ways of activating the complement system. The classical pathway activated would be by C1 and then bacterial pathogens. The lectin pathway activated typically by, again, pathogens, bacterial lectins. But then the alternative pathway is a pathway that's constitutively activated. And it's like a small dripping faucet, providing innate immune response in our system. This pathway converges on C3 convertase. Essentially, with C3, there's basically through the alternative pathway, there's a slow but continuous conversion to C3b, which then leads to sort of the development of the membrane attack complex. To prevent this pathway from going too fast, there are natural brakes on this pathway, and the really major component of this is complement factor H. It turns out this hit that we found in our genome-wide association study is in complement factor HR1, which serves as a brake to CFH. In other words, and so there are people who have mutations in this in this gene, and these folks appear to be protected from IgA nephropathy. So if you think about it, in other words, if this is gone, CFH can do a better job in terms of repressing the C3 convertase. There's less active conversion to C3b, and there's less complement activation. And as a result of this, the severity of disease is less. So how do we put all of these pathways together? Well, this is sort of the general pathogenesis that we're thinking about for IgA nephropathy. So on the one hand, we have the generation of galactose-deficient IgA, which is an inherited factor. And then the second part is the production of anti-glycan antibodies. Well, we found a number of factors through our GWASs that are important for the production of IgA and then innate and innate immunity, which converge on mucosal immunity and production of IgA. So we think a lot of these factors are here important in this step of the pathogenesis. The production of anti-glycan antibody seems to be determined by your MHC haplotype. So presumably, a lot of the family members will have elevated levels of galactose-deficient IgA but do not develop an anti-glycan response, have a protected MHC haplotype. This leads to formation of immune complexes, okay, which then deposit in the kidney and cause inflammation. And one of the major factors that govern and regulate this inflammation is the alternative complement pathway. So we're starting to put together a number of biological pathways into the pathogenesis model, and each of these, as you can imagine, is a potential therapeutic target. And so I'm going to talk a little bit more about this as we go forward. So we can also count the number of genetic risk factors that an individual has, and then you can come up with a genetic risk score. This is similar to having like a framing out risk score for heart disease, except that this is based on your genetics. And so you can count how many genetic risk factors an individual has, and then compute their sort of inherited risk for kidney disease. Now, this is not sufficiently precise to predict disease non-invasively of the individual who's in front of you, but it has interesting epidemiological applications. So if you remember, IgA nephropathy is really common in East Asia, but it's really uncommon in Africa, with Europeans being in between. And when I went to medical school, I was taught that the reason why IgA nephropathy is very common in Asia and in China is that the nephrologists are much more aggressive about doing kidney biopsies, so they ascertain the diagnosis much earlier. In Africa, there are not enough kidney doctors, and as a result of this, you don't make the diagnosis of IgA nephropathy. And in Europe and in North America, we do things perfectly, and so as a result of this, we come up with like an intermediate prevalence. Well, here's what we looked at the genetic risk for IgA nephropathy in 85 world populations. So this is in red, you have populations that have the highest genetic risk of IgA nephropathy. In green, you have populations that have the lowest genetic risk of IgA nephropathy. And you can see East Asians by far have the highest genetic risk, and then Africans have the lowest genetic risk, and Europeans are somewhere in between. So I think a large factor, explaining these differences in the prevalence and the epidemiology of IgA nephropathy is actually genetic predisposition. So the question, of course, is why is it that Asians have a higher genetic risk? When you think about it, humans evolved in Africa and then followed, migrated out about 100,000 years ago. So whenever you see some genetic risk factors that seem to be accumulating in certain parts of the world, you have to think about environmental factors that may have induced this sort of selection on certain genetic factors. And so we started looking a little bit more at the biology of these diseases and the genetic risk factors. And we did a pathway analysis, as I mentioned. The most common, the most significant signal in terms of the pathways, biological pathways that we found was the intestinal immune network for IgA. It makes sense, the intestine being the largest site for the production of IgA in our body. Well, what we did then was that we took this genetic risk score in these different populations and started correlating this with environmental factors that we knew about these populations: diet, temperature, lifestyle, and including pathogen diversity. And the genetic risk score that in these 85 populations, it turns out was most highly correlated with pathogen diversity. And when we looked at what are the type of pathogens that are leading this, it turns out helminth fact drivers, in other words, roundworms, intestinal pathogens, show the highest correlation with this. And it turns out that in East Asia in particular, in terms of pathogen diversity, you have the highest helminth diversity that's been noted across the globe. And these intestinal pathogens actually are a major cause of childhood morbidity and mortality even now. So we think that one of the reasons why some of these genetic risk factors are more prevalent in certain parts of the world, particularly in East Asia, is that they have arisen as a defense mechanism against environmental pathogens. But this, enabling survival at an early age, but this comes at the risk of developing IgA nephropathy later on in life. So this really makes us think about now investigating the biology in terms of the innate defense systems that are involved in pathogen, particularly helminth, interactions. The other thing that we started to look at is looking at the clinical correlations. And so we could look at these genetic risk factors and say, how are they associated with these, some important clinical parameters? So IgA nephropathy typically presents in the second or third decade of life. But if you really look at the number of risk alleles for genetic risk alleles for IgA nephropathy and compare this to the mean age of diagnosis, there's an inverse relationship. So in other words, people who have the highest genetic risk also present 20 years earlier than patients who have the lowest genetic risk. And we are not doing this type of analysis with other parameters such as risk for end-stage kidney failure, proteinuria, and response to therapy. And there are some early indicators that this is going to be also predictive in a large population. So we're very hopeful that this can be incorporated into the thinking about risk management in patients. So let's talk about a clinical case, since most of you are interested in this. This is a 54-year-old woman who's had hematuria and was diagnosed with IgA nephropathy about 20 years ago. She had a kidney biopsy. This is her finding M1, E1. This is the MES score. We're going to go over this in a minute. She's maximally treated with a angiotensin receptor blockade and furosemide. Her blood pressure is under good control, or reasonable control. Her creatinine is now about 1.9 to 2. She has, a creatinine, she still has proteinuria, basically. So what should we do next? And so this was sort of the audience response question that we had. Okay, all right. So how many people think that we should do ACE inhibitors? Okay. ACE inhibitors and, okay, so a few people. Fish oils, people use fish oils in, okay. A couple of people use fish oils. Steroids. Yeah, okay. The same people want to, okay. All right, good. you want to give everything out there. Okay, how about cyclophosphamide? Okay, one person wants to give cyclophosphamide at this point, okay. Good, how about MMF, mycophenolate? Silence in the room. Okay, and rituximab. Do we use rituximab? It's a B-cell disease. Do we still do we give rituximab? Okay, so we'll come back to this in a little while, okay, and think about this. So, what are some of the clinical prognostic factors for IgA nephropathy? So, GFR presentation is a good indicator of progression to kidney failure, but that's not specific, right? This is for every kidney disease that you see out there. You present with later with a higher GFR, the worse it is. Proteinuria is a very strong indicator of progression, hypertension, uncontrolled hypertension, atrophy and fibrosis and biopsy is. And then there's a bunch of other factors that have variable evidence, so depending on the studies that have been published, age, sex, race, in particular age and ancestry, persistent microhematuria, microscopic hematuria may be actually a protective factor, a bunch of other biopsy features, and we're going to talk about it, some biomarkers that we talked about earlier. So this is the MES classification system here. Agnes Fogo is here, so I'm not going to show any kind of biopsies here because it's going to be too embarrassing. But I'll show you the most important thing that I'm going to emphasize here is that there are, for each one of these sort of MES score subcategories, mesangial cytocellularity, endocapillary proliferation, segmental glomerulosclerosis, tuberointerstitial fibrosis, and crescents, which is a new addition to the score. There are certain classifications which are predictive of worst outcome, so the M1, the E1, the S1, all predictive of worst outcome. Some of them only in the setting of patient receiving no immunosuppression. Okay, so I think that's really important to realize also as you're trying to look at your prognostication. The one score that's been reproducibly found to be associated with worst outcome is tuberointerstitial disease, and showing fibrosis, as I mentioned. And this also shows the most consistency in terms of reproducibility across readings for pathologists. So this is a really important one to keep in mind as we go forward, and I think this has provided a really good tool to be able to standardize assessment of IgA nephropathy across populations, trying to think about it. The other part is proteinuria. So this is a study that was published a number of years ago by Dan Tran. You can see the associates looking at the relationship between TAM average proteinuria and GFR loss. You can see that with advanced proteinuria, there's absolutely a worse impact on kidney survival in membranous nephropathy, FSGS. But with IgA nephropathy, there's a very, very linear curve. So even small amounts of proteinuria are associated with worse outcomes. So this is something to really think about as you go forward. One of the things we did a number of years ago, based on a Chinese cohort of patients that had good follow-up data, we wound up developing looking for independent predictors, and we came up with a progression risk factor. Okay, and so this provides 5 to 10 year survival probabilities. And the 4 factors interesting in this cohort that we found were associated with risk of progression were glomerular filtration rate, hemoglobin levels, serum albumin, but not serum, urine protein. Although I think that's probably because it was confounded by the 2 here, and then systolic blood pressure. So you can go to this calculator and put in the numbers for your patients. It will give you some level of indication about whether the person has a high risk of progression or not. We're trying to refine this clinical indicator by studying larger cohorts of patients, and at the same time, we're trying to incorporate genetic factors in there. So let's think about therapy a little bit. How about what do we think about immunosuppression? What's the evidence? So if you think about historically, we really thought about steroids as being an accepted therapy for patients who had proteinuria in patients with IgA nephropathy. There were small randomized trials which showed that the 6-month course of glucocorticoids were beneficial. After 2015, we had a number of papers that showed that gave us pause, and I think that's the part that provides a conundrum now. And there are a number of other therapies that are on the horizon. These are the 3 studies that had been published previously showing that there is a benefit to steroids according to different regimens here. The numbers are very small, but they each showed consistent benefit with 6 months of steroids in the long term. in terms of the follow-up of the patients. So what happened then? In 2015, we had the STOP IgAN study that was published. This is a study looking at randomizing patients who had a GFR of more than 30 and had more than 0.75 grams per day of protein in their urine to either supportive care with renin-angiotensin blockers, statins, and so forth to reduce blood pressure, maximum reduce blood pressure, or randomize them to either prednisone for 6 months every other day, or to oral cyclophosphamide prednisone for 3 months followed by azathioprine prednisone in the group that had a GFR that was more compromised. And they wound up looking at two outcomes, which was really interesting here in the study. One was what they called remission, which was reduction of urine protein to less than 0.2 grams per day. And then the other one was progression, which was progression of GFR by more than 15 mLs per minute from the baseline. So the study involved 32 centers in Germany. What was really important to appreciate in the study is that in the run-in phase, nearly a third of the patients had responded. And so with aggressive blood pressure control with renin-angiotensin blockade. And this has been a reproducible finding across many studies. So being able to enter into a clinical trial where you are really rigorously controlled for blood pressure and for adherence to medication seems to be beneficial in reducing proteinuria in this disease. Now, there's a group of patients who do not respond but wind up fail to respond after some period of time. So what do we do with those guys? And this is what the study looked at for the remainder patients. This slide summarizes sort of the final disposition for the STOP IgAN study. Looking at the progression factor, there was absolutely no benefit in terms of progression. However, looking at their second outcome, which was proteinuria, there was a whole bunch of people, 17% versus 5%, who had a remission in terms of proteinuria when treated with immunosuppression. And then the rest of the folks just really didn't respond either way. So what gave pause in the study was that a high number of serious side effects, particularly infections and including death that occurred in the treatment arm. So if you exclude sort of the side effects that were deemed not to be related or likely unrelated to immunosuppression, you could see that infection was present in virtually every group with the immunosuppressive therapy. And the odds ratio was very high. So the conclusion from the investigator of the study is that the steroids immunosuppression is associated with an unacceptable risk for disease. There's no benefit in terms of progression. Maybe you see something for, some people respond with proteinuria, it probably doesn't justify it. You have to be able to really, you give pause before you start using immunosuppression and patient results. So the testing study is essentially a second study that was published that was mostly performed in an Asian and Chinese population. Now this is sort of looking at this as the exact same issue. This one had about 523 patients who were then in a running phase with the strict controlled blood pressure with renin-angiotensin blockade, and then they were randomized to either receiving methylprednisolone or they received placebo. So this was a randomized placebo-controlled trial to see what happens over this period of time. And this is the outcome that was published in JAMA. So the most important thing was that the study had to be stopped prematurely because of an increased number of serious side effects, particularly, again, infections. And when you look at it, the number of serious infections were incredibly high in this population. So again, this gave us pause about using immunosuppression in this population. Nonetheless, even though the study was stopped early, well, there were benefits that were observed. So there were benefits, statistically significant benefits that were observed in terms of GFR in the population, in terms of the primary endpoint, which was a combined endpoint of proteinuria and as well as a doubling or 50% increase in creatinine. And then also you look at it in terms of proteinuria. And these happened within 6 to 12 months of therapy. Note that the side effects, if I go back to the prior slide, occurred pretty early, within 6 months, of course, of the therapy. And so that's where the problem is that you have to sort of survive the side effects and the major infections to be able to get the benefit from steroids. So what's the conclusion we can make is that corticosteroids reduce proteinuria, maybe they reduce progression as well. The follow-up may be needed, longer follow-up may be needed. Maybe also differences in the populations that you wind up treating, because the testing study was mostly conducted in the Asian population. The sub-IgAN was mostly in Germany, and there may be differences, as you know, in terms of genetic risk factors for disease in this population. And it's been postulated that Asian patients tend to progress a lot faster. It's a very high rate of complications. So the question is, can you get the benefit without having some of the side effects? So this is where this enteric dosing of corticosteroids may be helpful. This is a study that was published just about a year and a half ago on using a formulation of steroids, which is administered through the essentially it's an intestinal version, which then gets released and does not enter into the systemic circulation. The idea here is that here you're acting on the Peyer's patches in the intestine, which are the highest sort of site of production for IgA, and so as a result, you may not have a lot of systemic effects. And so this showed promise in the first sort of phase 2b study, and there's a much larger study that's ongoing that will give us a better idea. So in terms of thinking about the pathogenesis model, going back to this and thinking about therapeutic targets, we have identified a number of pathways that seem to be important in the generation of IgA, or particularly the cytokine called TNF-SF13, so it also called APRIL, which is important for maturation of IgA-producing cells. And there are drugs that are now targeting TNF-SF13 and its receptor that are currently in clinical trials for IgA nephropathy. As I mentioned, you have the enteric formulation of steroids. Perhaps tonsillectomy, by reducing the load of IgA production, might be helpful. So again, most of the literature comes from Asia, but maybe there is an association. We think steroids will be helpful in terms of reducing the level of autoantibody production, and so that's also another part which might be helpful. But then we have to really think about all the side effects as well. And then finally, the renin-angiotensin blockades and the complement inhibitors. We're going to work on this last part of the equation, which is really the inflammatory component. And so there are studies with complement inhibitors that are ongoing as well for IgA nephropathy based on the GWAS findings that we have. We also have the spleen tyrosine kinase, which can reduce the inflammation in the kidney, its angioproliferation. It can also act on IgA-producing cells to reduce IgA production. So all of these will be upcoming. There are clinical trials that are underway, and we'll be able to have a much better appreciation of what to do for our patients going forward. So what are we going to do for these patients? So we could see that she's got a number of different risk factors, M1, E1, T1, C1. So all of these, or each one of them, confers a higher risk of progression. She's got elevated creatinine, she has elevated protein. The blood pressure is not under great control, so we could do better for this. So what's the best evidence? So addition of another ACE inhibitor to control blood pressure, there's plus and minuses to this, and there are some studies showing that this may not work so well in chronic kidney disease. But it might be worth trying in terms of getting the blood pressure under better control. Fish oils are low risk, but probably low benefit, and they're very difficult to take, and so most people stay away from them. Thinking about corticosteroids, well, if somebody's high is at high risk, there may be a role for this. And in fact, this is the pathway that we chose for this particular patient, to give prednisone about 60 milligrams a day, every other day for 6 months. And she actually had a good response to this with a reduction in proteinuria, and actually her creatinine also improved over time. Cyclophosphamide is also a reasonable response, particularly in patients who have an RPGN. And so with rapidly progressing disease, this is where we start to, what we tend to use, at least all the glomerular folks all the glomerular doctors at Columbia really reserve cyclophosphamide to people who have rapidly progressing disease. So we didn't think that she had rapidly progressive disease, and so we stayed away from that. There are small trials in mycophenolate, none of them are really convincing. And I'm not going to go into the details here with you, but I think that there's no really good evidence supporting mycophenolate. And there's a couple of negative studies for rituximab. So even though it's a B-cell mediated disease, rituximab may not be targeting the right B cells here in IgA nephropathy, so there is no evidence. So the key messages, I would say, in the treatment of IgA nephropathy, you got to think about the degree of proteinuria, think about the rate of progression and all the risk factors that the patient has. Some of the comorbidities, diabetes is another one that we have to think about in the setting of this disease. And how risk adverse are you, and how risk adverse is the patient in terms of thinking about the therapy with steroids. And then if significant proteinuria despite steroids, as I said, despite renin-angiotensin blockade, glucocorticoid is the most convincing option, and then the other ones are reasonable only for severe RPGN. MMF and rituximab, I think those are both. So I'll stop here. I wanted to thank a large number of individuals who have helped with the studies that we've done over the years in terms of the clinical research. Our group in the Colombian nephrology and pathology has been really great, and particularly Dr. Pietro Pineda, who gave me that case to discuss with you. That was one of his patients here. So we've had also genetic studies of IgA nephropathy that have gone from all over the world, and we have also participation from a site in Argentina from Hermann-Ternarki. So I think this is great, and so the next study that we're going to have on the genetics of IgA nephropathy will have an Argentinian cohort, and we'll be able to assess the risk of genetic risk of IgA in this population. So I'll stop here, and if you have any questions, take it later.
Abrimos para 3 preguntas al menos. La doctora Alice Fogo.
Thank you very much for an absolutely wonderful talk, Ali. I have a question about looking at the clinical trials done with IgA nephropathy. It hasn't been the model, particularly if we take stop IgA nephropathy, to consider biopsy features when randomizing patients or on the front end of how to balance arms of the trial. Do you think that the biopsy findings should enter into how we construct or plan the trials on the front end, or just be mined in post-hoc analysis to see what was it that we treated in terms of the pathology?
I think you bring up an excellent point. A lot of these studies were started before we had a lot of data about the messenger, so I think there was hesitation. There's also concern about always trying to bring the biopsies together and then procure all the biopsies, which sometimes can be difficult to transmit. Nowadays, with digital technology, you should be able to do this, and I think there's definitely a room for looking at these patients with highest risk based on kidney biopsy, and then randomize those guys preferentially to the more aggressive treatment. So I think that's absolutely the way to go for the next set of trials.
Or even post-hoc analysis in some of these trials, even though it would take some effort to get virtual slide scans. We are doing this with the working groups for IgA nephropathy, and it's possible that it might enable one to fine-tune a little bit better if there is any added prediction at all in a clinical trial of those who do very well and those who do very well.
Absolutely. I think that's really going to be important to do.
¿Alguna otra pregunta? Dale. La genética nos permite identificar a aquellos pacientes que pueden desarrollar la enfermedad o aquellos que incluso pueden hacerlo tempranamente. ¿Puede ayudarnos a identificar el grupo de pacientes que no van a responder adecuadamente a un bloqueo del sistema renin-angiotensina o a inmunosupresión?
I think this is really, pharmacogenetics is a very sort of hot area in genetics, not just for kidney diseases, but all therapeutics. And so there's going to be, now that we collect all these data, we're going to be able to sort of do a post-hoc analysis, so to speak, to see whether some people with certain genetic factors respond better. But there are no sort of already identified genetic risk factors in terms of response to therapy. And so this area is still sort of lagging behind. When you think about cancer therapy, there's a lot of genetic data that drives therapy. And so we hope that in the future we're going to be able to do this as we sequence more patients with kidney diseases and come up with better indicators of response across different populations.
Thank you very much.